All right, let's do this. We're diving deep today into a system that's pretty crucial, for, well, staying alive.
Can't argue with that. The cardiovascular system, the heart, the blood vessels, the whole circulatory show.
It's a big one. And especially for a nursing student like you, it's, got to be pretty central to what you're learning there.
Oh, absolutely. Understanding the cardiovascular system inside and out, that's like essential for taking care of patients.
Exactly. And speaking of learning, you sent over some seriously impressive notes.
Well, I've been hitting the books, yeah.
Hypertension, valvular disease, heart failure, you've got it all covered. So, ready to break it all down, highlight those key points, really make this stuff stick.
Let's do it.
Okay, so the heart, it's the engine, the pump, what's the best metaphor? I don't even know.
It's a pretty amazing organ, that's for sure.
But it's not just like one big squeeze, right? There's a whole pathway, an intricate route that blood takes through the heart.
Right. It's like a perfectly choreographed dance, blood moving through different chambers, valves opening and closing. It's kind of beautiful when you think about it.
So let's trace that path step by step. Where does this circulatory journey begin?
Okay, so picture this. Blood's been circulating through the body, doing its thing, delivering oxygen, picking up waste, and now it's coming back to the heart, entering through these large veins, the superior and inferior vena cava.
Okay, the vena cava bringing blood back to the heart.
Right, and from there, it flows into the first chamber, the right atrium.
Right atrium. First, stop on the heart tour.
Then, through the tricuspid valve, it goes into the right ventricle.
Tricuspid valve, right ventricle, got it. So what's next?
Next stop, the lungs.
The lungs, of course. Got to get that oxygen.
Exactly. So the blood gets pumped through the pulmonic valve, into the pulmonary arteries, and off to the lungs it goes.
Pulmonic valve, pulmonary arteries on its way to get oxygenated. But wait a minute. Isn't there something special about the pulmonary arteries?
Oh, good catch. You're thinking about how they're the only arteries in the whole body that carry deoxygenated blood.
Exactly. That always tripped me up. It's like the exception to the rule.
It is. But it makes sense when you think about it. The blood's on its way to the lungs to pick up oxygen, so it's still in its deoxygenated form.
Makes sense. So once it's loaded up with oxygen in the lungs, where does it go?
Back to the heart it goes, this time through the pulmonary veins.
Okay, so we've got pulmonary veins carrying oxygen-rich blood back to the heart.
Right, and it enters the left atrium this time.
Left atrium. Got it. What happens next?
It goes through the mitral valve into the left ventricle.
Motor valve, left ventricle. And this is where the real pumping action happens, right?
This is it. The left ventricle is the heart's powerhouse. It gives that final push, pumping the oxygen-rich blood out through the aortic valve and into the aorta.
Aortic valve, aorta. That's the big one, the body's main highway for blood.
Exactly. And from the aorta, the blood branches out into smaller and smaller arteries, delivering that precious oxygen to every cell in the body. It's an amazing system, really.
Like a perfectly designed delivery network. Now, your notes use a really helpful analogy to describe the heart's structure and function. Pipes and wires.
Ah, yes, the pipes and wires. A classic way to visualize it.
So, help me out here. The pipes, those are the
blood vessels, of course. Your arteries, veins, capillaries, the whole intricate network that carries blood throughout the body.
Okay, the plumbing of the circulatory system. Got it. And what about the wires?
Those are the specialized cells that generate and conduct electrical impulses. They're the ones that tell your heart when to contract and relax, keeping that rhythm going.
Like the heart's own electrical grid.
Exactly. And that electrical activity is what we're listening for when we use a stethoscope. We're hearing the sounds of the heart valves opening and closing as the heart goes through its cycle of contraction and relaxation.
Okay, so let's talk about that cycle. Contraction and relaxation. I remember those terms. Systole and diastole.
Right. Systole is the contraction phase. That's when the ventricles squeeze, pushing blood out the lungs and the body.
Systole, the big squeeze. And diastole.
Diastole is the relaxation phase, when the ventricles refill with blood, getting ready for the next contraction.
Okay, so systole is like the heart flexing its muscles, and diastole is like it taking a breather.
A very important breather, because that's when the heart muscle itself gets its own blood supply.
Wait, really? Even the heart needs its own blood supply?
Oh, absolutely. The heart works hard. It needs oxygen and nutrients just like any other organ.
So how does it get that blood if it's busy pumping blood to the rest of the body?
That's where diastole comes in. During diastole, when the heart muscle is relaxed, the coronary arteries, those are the blood vessels that supply the heart, they get their chance to deliver blood to the heart muscle.
So it's like the heart is taking a quick pit stop to refuel itself before the next round of pumping.
Exactly. Pretty clever, isn't it?
It is. And of course, we can't forget those classic heart sounds, the lub-dub.
Ah, the soundtrack to a healthy heart. Those sounds are actually the heart valves closing.
So the lub is one valve closing and the dub is another.
You got it. The lub, or S1, happens when the atrioventricular valves, those are the tricuspid and mitral valves, they close at the beginning of systole.
So the lub is the AV valves closing. What about the dub?
The dub, or S2, that's when the semilunar valves, the pulmonic and aortic valves, close at the end of systole.
Okay, so lub is AV valves, dub is semilunar valves.
Got it.
And all this pumping, all this blood flowing, it's measured as cardiac output, right? That's the volume of blood the heart pumps per minute.
Exactly. Cardiac output. It's a key indicator of how well the heart is functioning. And it's a concept that will come up a lot, especially when we delve into heart failure.
Okay, so we've got the heart basics down, the chambers, the valves, the electrical system, the whole shebang. Now, let's tackle one of the big players in cardiology, hypertension.
Or, as it's more commonly known, high blood pressure. The silent killer, they call it.
Silent killer. Sounds ominous. Why is it called that?
Because it can be sneaky. A lot of people don't even know they have it until it's already causing problems. No symptoms, just, well, silently damaging your blood vessels and organs.
Yeesh. Okay, definitely not something to mess around with. So what exactly is hypertension? What makes blood pressure high?
Clinically, we're talking numbers. Systolic blood pressure, that's the pressure when your heart contracts. That needs to be 140 millimeters of mercury, or MHE, or higher for a diagnosis of hypertension. Or your diastolic blood pressure, the pressure when your heart relaxes between beats, has to be 90 millimol Hg or higher. Either one does the trick.
So either number being high is enough. But here's what always gets me. A lot of times there isn't one single cause for hypertension, and it's not like, boom, this one thing caused it. It's kind of a mystery sometimes, right?
Right. Doctors call it primary hypertension, and it's a whole mix of factors. Genetics plays a role, definitely. But then there's lifestyle, things you do every day, diet, how much you exercise, how you handle stress, even whether you smoke. All of that can contribute. And then as we get older, well, our bodies just don't work quite as smoothly as they used to.
Okay, so genetics we can't control, unfortunately. But lifestyle, that's where we can make a difference.
Exactly. And speaking of getting older, you know what else becomes less effective with age? Those pressure sensors in our blood vessels, the baroreceptors.
Baroreceptors, those are the ones that keep blood pressure stable, right?
Right. They're supposed to sense changes in blood pressure and signal the body to adjust. But as we age, they don't work quite as well, so our blood pressure can creep up, and we might not even realize it.
So it's like our internal control system gets a little rusty.
Mm-hmm.
Okay, but even if hypertension can be silent, there must be some signs, some red flags to watch out for, right?
Definitely. Fatigue is a big one. Feeling tired more often, even after a good night's sleep. And then there's stamina, or lack of it. You might find yourself getting winded more easily, even with everyday activities.
Okay, so fatigue, less stamina, what else?
Dizziness can be a sign, feeling lightheaded or unsteady. Some people experience palpitations, feeling their heart pounding in their chest. And then, well, this one's more serious. Chest pain.
Chest pain. That doesn't sound good.
It's not. It could be angina, which means your heart isn't getting enough oxygen. That's a definite warning sign that something's wrong.
Whoa, angina. Okay, that's one to take seriously. So let's say someone is experiencing some of these symptoms. How do doctors actually diagnose hypertension?
The first step is always measuring blood pressure, of course. But it's not as simple as just taking one reading and calling it a day. You've probably heard of white coat syndrome.
Oh, yeah, that's when your blood pressure goes up. Just because you're at the doctor's office, right?
Yeah.
Happens to me every time.
Exactly. So sometimes home blood pressure monitoring is needed to get a more accurate picture. And sometimes multiple readings over several visits are needed to confirm the diagnosis. But it's crucial to catch it early, because if hypertension goes untreated, it can lead to some serious complications.
Like what? What kind of damage are we talking about here?
Well, think about all those blood vessels that are under constant pressure. The heart is working overtime, so it can become enlarged and weakened. The kidneys can be damaged, affecting their ability to filter waste. The brain is at risk for stroke, and the eyes can be damaged, even leading to vision loss. And even the blood vessels in the limbs can be affected, potentially leading to amputations in severe cases. It's a domino effect, really.
Wow, okay, so hypertension is definitely not something to ignore. But the good news is there are ways to manage it, right?
Absolutely. Lifestyle changes are key. Things like diet, exercise, stress management, and then, of course, there are medications.
Your notes have a whole section on different types of medications for hypertension. Diuretics, vasodilators, beta blockers, ACE inhibitors. The list goes on. It can be pretty overwhelming.
It is a lot to keep track of, and each type of medication works in a slightly different way, targeting different parts of the cardiovascular system.
So how do doctors decide which medication is right for a patient?
It's a combination of factors: the severity of the hypertension, the patient's overall health, any other conditions they might have, even their preferences and lifestyle. It's personalized medicine, really.
Makes sense. So the main goal of these medications is
To lower blood pressure, of course. But how they do that, well, that depends on the specific drug. But one important target is something called systemic vascular resistance, or SVR for short.
okay, SCR. What's that?
Think of it as the resistance the heart has to pump against. High SVR means the heart is working harder to push blood through the blood vessels, and that extra effort can put a lot of strain on the heart.
So medications can help reduce that resistance, making it easier for the heart to do its job.
Exactly. And along with lowering SVR, some medications also work by reducing preload, which is the amount of blood returning to the heart.
Preload, got it. So by lowering both SVR and preload, we can effectively bring down blood pressure and give the heart a break.
Precisely. It's all about teamwork, really. The heart, the blood vessels, and the medications all working together to keep blood pressure in a healthy range.
Okay, so we've covered the heart's basic function and the challenges of hypertension. Now, ready to move on to those crucial gatekeepers of blood flow,
What about the valves?
the valves, those unsung heroes of the cardiovascular system. Let's dive into their world and see what happens when they don't play by the rules.
Sounds good to me. All right, welcome back to our cardiovascular deep dive.
We've covered a lot of ground already. The heart's anatomy, how it pumps blood, the whole silent killer thing with hypertension. It's a lot to take in.
It is. But we're just getting started.
Oh, good. So what's next on the agenda?
Let's talk about heart valves. Those often overlooked but absolutely essential players in the circulatory system.
Valves. Okay, so those are the guys that make sure blood flows in the right direction.
Exactly. Think of them as gatekeepers, making sure blood goes forward and doesn't leak back where it came from, kind of like a one-way street for blood flow.
Right, one-way street. So what happens when those gatekeepers don't do their job? When something goes wrong with the valves?
That's when we get valvular disease, and it can really throw a wrench in the heart's smooth operation. Remember, we have 4 valves: tricuspid, mitral, pulmonic, and aortic.
4 valves, okay, and each one is basically making sure blood flows in the right direction. What are the ways a valve can malfunction?
2 main ways: stenosis and regurgitation.
Stenosis and regurgitation. Those sound like fun medical terms. Break it down for me.
Stenosis basically means the valve opening is narrowed, so it's harder for blood to get through. Imagine trying to squeeze a whole crowd through a narrow doorway. Not
Right.
very efficient, right?
Not efficient at all.
Yeah.
And that puts extra strain on the heart, I imagine. So what causes that narrowing? Why do valves get stenotic?
A few reasons. It could be calcium buildup, kind of like how your arteries can get clogged with plaque, or sometimes it's scarring from an injury or infection.
So the valve gets stiff and inflexible, making it hard for blood to pass through. Okay, what about regurgitation? What's going on there?
Regurgitation is when the valve doesn't close tightly, so blood can leak back in the wrong direction. It's like a leaky faucet, wasting precious blood flow.
So stenosis is a tight squeeze, and regurgitation is a leaky valve.
Got it. And this can happen to any of the 4 valves.
Any one of them. And it can lead to a whole range of symptoms like shortness of breath, fatigue, dizziness, even chest pain.
Sounds familiar. A lot of overlap with hypertension, it seems. But there's one telltale sign that often points to valve problems: heart murmurs.
Ah, yes, heart murmurs.
Yeah.
The whooshing and swishing sounds.
So it's not just the regular lub-dub.
Right. A murmur is an extra sound caused by turbulent blood flow, often because of a faulty valve.
So doctors and nurses are listening for those extra sounds, trying to figure out what's going on. Exactly. And they use both the diaphragm and the bell of the stethoscope to listen.
Wait, why 2 different parts?
They pick up different frequencies of sound. It's like having 2 different microphones, one for high-pitched sounds and one for low-pitched. That way, they can really hear all the nuances of those murmurs.
So it's like a sonic fingerprint for the heart. Okay, and then if they suspect a valve problem, they can confirm it with an echocardiogram.
You got it. An echocardiogram is basically an ultrasound of the heart. It creates images of the valves in action, showing how well they're opening and closing. It's pretty amazing technology, really.
So it's like peeking inside the heart to see those valves in action. Cool. But let's say the echocardiogram shows there's a problem. What happens then?
Well, it depends on the severity and which valve is affected. Sometimes medication is enough to manage symptoms and prevent complications.
So medications can help support the heart even when there's a valve problem.
They can. Things like diuretics to help get rid of excess fluid, beta blockers to slow down the heart rate, and even blood thinners to prevent clots. It's like providing extra support while the heart is dealing with the valve issue.
Okay, makes sense. But what happens when medication isn't enough? When the problem is more serious?
Then we might consider valve repair or replacement.
Whoa, now we're talking surgery.
Valve repair is always the preferred option if possible. The goal is to fix the damaged valve while preserving as much of the natural structure as we can.
So it's less invasive than a full replacement.
Exactly, like patching up a leaky roof instead of replacing the whole thing. There are some amazing techniques surgeons can use. Widening a narrowed valve opening, stretching a stiff valve, even repairing the valve's ring to improve its function.
Wow, it's incredible what they can do with these tiny structures.
It is, but sometimes repair just isn't an option. The valve might be too damaged, or the risk of complications might be too high. In those cases, we have to replace the valve.
Okay, so that's when they take out the old faulty valve and put in a new one. But where do those new valves come from? Do they just have spare heart valves lying around?
Not quite. There are two main types of prosthetic valves: mechanical valves and bioprosthetic valves.
Mechanical valves, bioprosthetic valves, what's the difference?
Mechanical valves are made from durable materials like metal or carbon. They're super strong and tend to last a long time.
So it's like having a tiny, high-tech gadget implanted in your heart.
Exactly. But there's a catch. People with mechanical valves usually need to take blood thinners for life to prevent clots from forming.
So there's a trade-off. Durability, but with the added need for blood thinners. What about bioprosthetic valves?
Those are made from animal tissue, usually pig or cow valves.
Wait, so you could potentially have a pig's valve in your heart?
It's possible. They work really well and don't usually require lifelong blood thinners, but the downside is they might not last as long as mechanical valves.
So it's a balancing act. Durability versus the need for blood thinners. How do doctors decide which type of valve is best?
It's a case-by-case decision. Doctors consider the patient's age, overall health, lifestyle, and their preferences.
Makes sense. It's a big decision after all.
Yeah.
But ultimately, the goal is to restore that smooth, efficient blood flow through the heart.
Exactly. And that brings us to another major player in cardiology, one that can actually result from all the things we've discussed so far.
Wow. Okay, lay it on me. What's next on our cardiovascular adventure?
Let's dive into heart failure.
Heart failure. Now, that's a term that definitely grabs your attention. And your notes mention some pretty alarming statistics about it.
Unfortunately, you're right. It's a leading cause of hospitalization, and the numbers aren't great. About 30% of people diagnosed with heart failure don't make it past the 1-year mark.
Wow, that's a sobering reality check.
Yeah.
So, heart failure. What exactly is happening in the body when someone has heart failure?
In simplest terms, the heart can't keep up. It's like a pump that's losing its power. It can't pump enough blood to meet the body's demands for oxygen and nutrients.
So everything slows down, organs don't get what they need. That's why it's so serious.
Right. And if you remember our talk about cardiac output, the amount of blood the heart pumps each minute, well, in heart failure, cardiac output takes a nosedive.
Cardiac output plummets.
Got it. And we know that cardiac output is affected by heart rate and stroke volume.
Exactly. And stroke volume, the amount of blood pumped with each beat, well, that's influenced by a few things: preload, afterload, and contractility.
Okay, back to those terms. So preload, that's the amount of blood returning to the heart, right?
Think of it like filling a bathtub. The more water you put in, the higher the preload.
Okay, filling the bathtub and afterload.
Afterload is the resistance the heart has to pump against. It's like the size of the drain. A smaller drain creates more resistance.
Got it. So preload is filling the tub, afterload is the drain size. What about contractility?
Contractility is how forcefully the heart muscle contracts. A strong muscle can squeeze harder and pump more blood with each beat. Okay, so all those things can affect stroke volume, which then affects cardiac output. And any of those things being off can lead to heart failure.
Precisely. Now, your notes list a bunch of things that can cause heart failure. Some we've already talked about.
Like coronary artery disease, hypertension.
Right, those are big ones. They can damage the heart muscle, make it weaker and less efficient.
So they're kind of like the usual suspects in a heart failure case.
They are. But there are other culprits, too. Things that might surprise you.
Like what?
Well, lifestyle choices play a role. Alcohol consumption, smoking, lack of exercise, all those things can take a toll on the heart over time.
It's another reminder that healthy habits really matter. Okay, what else? Anything else in those notes that jumped out at you?
Well, you mentioned cardiomyopathy earlier.
Cardiomyopathy, yeah. What exactly is that?
It's a disease of the heart muscle itself. The muscle can become weakened, thickened, or stiff, making it less effective at pumping.
So it's like the heart is trying to do its job, but with faulty equipment.
A good way to put it. And there are different types of cardiomyopathy, each with its own quirks.
Like what?
Well, you've got dilated cardiomyopathy. That's where the heart chambers become enlarged and weak, like an overstretched balloon. Then there's hypertrophic cardiomyopathy. That's when the heart muscle, especially in the left ventricle, gets abnormally thick, making it harder for the heart to fill with blood.
Okay, so dilated, hypertrophic, what else?
And then there's restrictive cardiomyopathy. In this type, the heart muscle becomes stiff and rigid, making it hard to fill with blood. It's like trying to fill a container that's already full.
So 3 different types of cardiomyopathy, each affecting the heart muscle in a different way.
Right. And knowing the type can help healthcare providers anticipate what the patient might be experiencing and tailor the treatment plan accordingly.
Makes sense. Now, there's another concept that comes up a lot with heart failure. Ejection fraction?
Ejection fraction, the percentage of blood pumped out of the left ventricle with each beat.
Right, like a measure of how efficiently the heart is emptying with each squeeze.
Exactly. A normal ejection fraction is usually between 55% and 65%, but in heart failure, it can drop significantly.
So it's like a car engine that's only firing on half its cylinders. Not good. Yeah. So how do doctors actually diagnose heart failure? I imagine it's more than just listening to the heart.
It is. They'll look at the patient's symptoms, their medical history, do a physical exam. They'll listen to the heart and lungs, check for swelling in the legs, that sort of thing. But to really confirm the diagnosis, they'll often order some tests.
Like an echocardiogram, maybe?
Bingo. An echocardiogram can show how well the heart is pumping and if there's any damage. And then there's a blood test that can be really helpful. They look for a marker called B-type natriuretic peptide, or BNP for short.
BNP, yeah, I remember that from my notes. Isn't that the one that was discovered in pig brains?
That's the one. Turns out, pig brains played a key role in understanding heart failure. When the heart is stretched and strained, it releases BNP. So elevated levels in the blood can be a strong indicator of heart failure.
Who knew pig brains held the key to understanding human hearts? Science is full of surprises. Okay, so BNP is one way to diagnose heart failure. What else?
Well, just like hypertension, heart failure is classified into different stages.
Based on severity, right? How bad the symptoms are and how much they limit activity.
Exactly. Class 1 is the mildest, no symptoms during normal activity. Then class 2, you start to get mild symptoms during everyday activities.
Okay, so class 1 is mild, class 2 is a bit more noticeable.
Right. Then class 3, that's when things get more serious. You have significant symptoms even with less than usual activity.
Class 3, symptoms even with less activity.
Right. And then class 4, that's the most severe. You have symptoms even at rest.
Wow, even at rest. So it's a progressive condition.
It is. It can worsen over time, which is why early detection and management are so important.
Makes sense. Catch it early, slow down the progression.
Exactly. Now here's where things get really interesting. The body actually tries to compensate for the struggling heart.
Oh, right. Our bodies are pretty good at adapting, aren't they? Trying to make things work, even when things aren't quite right.
They are. Your notes talk about several compensatory mechanisms. One of the first things that happens is the sympathetic nervous system kicks in.
Sympathetic nervous system, that's our fight or flight response.
That's it. So the body senses something's wrong and it's like, okay, time to go into overdrive.
So it's like revving the engine of a car that's sputtering.
Perfect analogy. It releases hormones like adrenaline and noradrenaline, which increase heart rate, make those contractions stronger, constrict blood vessels, all to try and boost blood pressure and get more blood flowing.
It's trying to help, but is it actually helpful?
Well, in the short term, maybe. But
Right.
long term, this overdrive mode can actually be harmful. It puts even more strain on the already struggling heart.
So it's like a vicious cycle.
It can be. Then there's the neurohormonal response, where the body releases hormones like renin and antidiuretic hormone. These guys make the body hold on to more fluid and constrict blood vessels even further.
So again, it's trying to help by increasing blood volume and pressure, but it's actually making things worse.
Unfortunately, often yes. And then there are the changes in the heart itself.
Oh, right. The ventricles, those pumping chambers, they can actually start to change shape.
They can. They can dilate, meaning they stretch out and become bigger. This can help initially, accommodating more blood, but eventually it weakens the heart muscle, or they can hypertrophy, meaning the muscle walls thicken, which can increase the force of contraction, but it also makes the heart less flexible.
So it's like a double-edged sword. These compensatory mechanisms are trying to help, but they can backfire, making things worse in the long run.
Exactly. And all of this can lead to a whole host of complications.
Like what kind of complications?
Well, think about fluid backing up into the lungs. That can cause pleural effusion, making it hard to breathe. Then there's the strain on the heart's electrical system. That can lead to dysrhythmias or irregular heartbeats. And there's always the risk of blood clots forming, which can travel to the lungs and cause a pulmonary embolism.
Wow, it's like a domino effect. One thing leads to another. So with all these potential complications, how do doctors and nurses manage heart failure? What can they do to help?
The main goal is to improve cardiac output and reduce those debilitating symptoms. Now, in acute heart failure, when things are really critical, it's all about stabilizing the patient.
So it's like damage control, trying to get things under control quickly.
Exactly. That might involve getting rid of excess fluid, giving oxygen, and using medications to support blood pressure and heart function.
Okay, so that's acute heart failure. What about chronic heart failure? That's more of a long-term situation, right?
Right. With chronic heart failure, the approach is more about managing symptoms, slowing down the progression of the disease, and preventing those complications we talk about.
So it's a different approach.
It is. We want to give the heart every chance to rest and recover. That means encouraging a healthy diet, regular exercise, as much as the patient can tolerate, of course, and finding ways to manage stress.
So a holistic approach,
Yeah.
looking at the whole person, not just the heart.
Exactly. And then there are the medications. Your notes list quite a few, each one working in a slightly different way to support the heart.
Right. We've got diuretics to help get rid of excess fluid, beta blockers to slow down that racing heart, ACE inhibitors to relax blood vessels. And then there's digoxin to help the heart contract more forcefully.
Exactly. And there are even newer medications like ARNIs and SGLT2 inhibitors that are showing a lot of promise in treating heart failure. It's amazing how research keeps coming up with new ways to help the heart.
It really is. But managing all these medications must be pretty complicated for both patients and their healthcare providers.
It can be. It takes careful monitoring, adjusting doses as needed, and open communication between the patient and their healthcare team. We want to make sure the patient understands their medications, why they're taking them, how to take them properly, and what side effects to watch out for.
So it's a real team effort. The patient, the doctor, the nurses, everyone working together.
Absolutely. Teamwork is key to successful heart failure management.
Now let's talk about the crucial role nurses play in all this. Your notes mention specific assessments nurses do, like checking for jugular vein distension. That's a sign of fluid overload, right?
Exactly. They're also trained to listen for specific heart sounds, like an S3 gallop, which can be a sign of a ventricle that's not filling properly. And they're experts at assessing for peripheral edema, that swelling in the legs and ankles that comes with fluid retention.
So they're gathering all these clues, putting the pieces together to get a complete picture of the patient's condition.
Exactly. It's like detective work, really. And then there's that intriguing term, pulse deficit.
Pulse deficit, yeah, what's that all about?
Remember how we said that not every heartbeat is strong enough to generate a palpable pulse? That's what a pulse deficit is.
Okay, so if the heart rate you hear through the stethoscope doesn't match the pulse you feel at the wrist, that's a sign of a pulse deficit.
Right, and it could indicate an irregular heart rhythm, like atrial fibrillation.
So a subtle but important finding. And based on all these assessments, nurses can make sure the patient is getting the right treatment and support.
Absolutely. They monitor vital signs, adjust oxygen therapy, make sure the patient is comfortable, and they're constantly advocating for their patient's needs.
It's a demanding role, but also incredibly rewarding, I imagine.
It is. Nurses are truly on the front lines of heart failure care, making a real difference in patients' lives.
We've covered so much ground in this deep dive. Hypertension, valvular disease, heart failure. It's amazing how interconnected it all is.
It really is. The cardiovascular system is like a complex web, and when one part of the web is affected, it can have ripple effects throughout the entire system.
So true. But with knowledge comes power, right?
Absolutely. The more you understand about these conditions, the better equipped you'll be to provide excellent care as a nurse.
Right. Okay, ready for the final leg of our cardiovascular journey.
Bring it on. Let's do it.
Okay, we're back. Final stretch of our deep dive into the cardiovascular system.
It's been quite a journey, hasn't it? The heart, the blood vessels, the conditions that can affect them.
It's a lot. But it's also fascinating, especially when you think about the role nurses play in caring for patients with these conditions.
Oh, absolutely. Nurses are the ones on the front lines, using their knowledge and skills to make a real difference in patients' lives every day.
So in this final part, I really want to focus on that, the nursing perspective.
Hmm.
What are some of the key ways nurses help patients navigate these cardiovascular challenges?
Sounds good to me. Let's zoom in on those nursing superpowers.
Perfect. Now, your notes mention something called a focused cardiovascular assessment. It sounds pretty intense. What exactly does that involve?
It's basically a way for nurses to gather information about a patient's cardiovascular health. They're looking for clues, trying to understand what's going on, and spotting any potential problems.
So it's like a detective's investigation, but for the heart.
Exactly. And they use a combination of techniques, observation, touch, and listening.
Okay, so it's a multi-sensory approach.
Right. First, there's inspection, which is simply observing the patient, looking at their skin color. Is it pale? Bluish? That could indicate poor circulation. Are there signs of swelling? That could suggest fluid buildup. Those visual cues can be really telling.
It's amazing how much information you can gather just by looking closely.
It is. Then there's palpation, which is using touch to gather information. Nurses will feel for the heart's rhythm. Is it regular, irregular, strong, weak? They'll also check peripheral pulses, making sure blood is flowing properly to the extremities.
So inspection, palpation, what's the third technique?
Auscultation. That's the fancy term for listening with a stethoscope. We've talked about murmurs, those extra heart sounds, but nurses are also listening to the heart rate, the rhythm, and any other unusual sounds.
Like an S3 gallop, right? That can indicate a problem with how the ventricle is filling.
Exactly. So they're really tuning into the heart symphony, making sure everything is playing in harmony.
That's a great way to put it. And all of these assessments help nurses build a comprehensive understanding of the patient's cardiovascular health. And that understanding then guides the care plan.
Right. It's all connected. Now, besides those focused assessments, nurses also play a crucial role in managing medications.
Oh, absolutely. Especially for conditions like hypertension and heart failure, where medications are such a big part of treatment.
Exactly. Nurses are responsible for administering medications, monitoring for both the intended effects and any side effects, and educating patients about their medications. It's a lot of responsibility.
It's a lot, but they're experts at it.
They are. They handle everything from IV meds in acute situations to oral medications for long-term management, and they're constantly monitoring, making sure everything is safe and effective.
Like medication guardians.
I like that. And they're also fantastic educators. They take the time to explain to patients what each medication does, why they're taking it, how to take it properly, and any potential side effects to watch out for.
So it's not just about giving the medication, it's about empowering the patient to understand their medications.
Exactly. It's about partnership, working together to manage the condition.
Okay, so we've talked about assessments, medication management. What are some other key ways nurses help patients with specific cardiovascular conditions? Let's start with hypertension.
With hypertension, nurses are big proponents of lifestyle changes. They talk to patients about the importance of diet, exercise, stress management, and of course, quitting smoking.
So they're like health coaches, encouraging healthy habits.
Exactly. And they're also monitoring blood pressure really closely, checking to see if the medications are working and watching for any side effects. They work closely with doctors to make adjustments to medications if needed.
So it's a team effort.
It is. And nurses are also really attuned to the emotional side of things. They know that stress and anxiety can impact blood pressure, so they provide support, counseling, and they can connect patients with resources to help them cope.
That's so important. It's not just about the physical symptoms, it's about the whole person.
Right. Now, what about valvular disease? How do nurses support patients with that?
Valvular disease, yeah. That one can be tricky.
It can. Nurses are always on the lookout for any signs that the valve function might be getting worse. Shortness of breath, fatigue, dizziness, chest pain. Those are all red flags.
So they're like watchdogs, always vigilant.
Yes, exactly. And they're also watching for complications like heart failure or irregular heart rhythms. They're experts at educating patients about their condition, about lifestyle changes, about medications.
So they're constantly evaluating and adjusting the care plan, making sure the patient is getting the best possible treatment.
Absolutely. And when surgery is needed, like a valve repair or replacement, nurses play a vital role before and after the procedure. They explain what to expect, offer support, and they're monitoring really closely for any complications.
It's a demanding role, but so crucial.
It is. And their support doesn't end when the patient goes home. Nurses help patients navigate life after surgery. They help them manage their medications, figure out their activity levels, make sure they're going to follow up appointments.
It's a true partnership.
Yeah.
Okay, let's talk about heart failure. That one's a big one.
Heart failure is definitely a complex condition, and it can be incredibly challenging for patients. But nurses are there every step of the way, guiding them through the process.
Like navigators helping patients chart a course through their heart failure journey.
I like that. And your notes highlight several key areas nurses focus on: medication management, fluid balance monitoring, patient education, and psychosocial support.
Okay, let's break those down. Let's start with medication management. We know that heart failure often involves multiple medications, each with specific doses and potential side effects. How do nurses keep it all straight?
Well, they're experts at it. They make sure each medication is given at the right time, in the right dose, and in the right way. They're monitoring for both the good effects and the bad, making sure the medications are working, but also watching for any side effects.
So they're constantly communicating with the doctor, adjusting the medications as needed.
Right. And they're also explaining everything to the patient, making sure they understand their medications, why they're taking them, how to take them, what to watch out for. It's all about empowering the patient to take an active role in their care.
Okay, so that's medication management. What about fluid balance?
Fluid balance is huge in heart failure. Fluid retention is a common problem, so nurses are really focused on monitoring fluid intake and output.
So they're keeping track of everything that goes in and everything that comes out.
You got it. They're tracking daily weights, measuring urine output, checking for swelling, and they're listening to the lungs for any signs of fluid buildup.
It's like they're piecing together a puzzle, using all these clues to get a complete picture of the patient's fluid status.
Exactly. And based on what they find, they'll adjust fluid restrictions, give diuretics if needed, and they'll teach the patient how to monitor their fluid status at home.
Again, it's about partnership. The nurse and the patient working together.
Right. And then there's patient education. Nurses are amazing teachers, explaining all the ins and outs of heart failure. They talk about the importance of lifestyle changes, how to manage medications, what warning signs to watch for.
They're giving patients the tools they need to be proactive about their health.
Exactly. And finally, there's psychosocial support. Living with heart failure can be incredibly tough, both physically and emotionally. Nurses recognize that, and they provide a lot of support. They listen, they offer encouragement, they connect patients with resources like support groups and counseling services.
So they're really caring for the whole person, not just the physical symptoms.
Absolutely. That holistic approach is what makes nurses such amazing caregivers.
Well, we've come to the end of our cardiovascular deep dive. And I have to say, I'm blown away by the expertise and dedication of nurses. They really are the backbone of healthcare.
Couldn't agree more. Their knowledge, their skills, their compassion, it all makes a huge difference in the lives of their patients.
And for you, as a future nurse, I hope this deep dive has given you a glimpse of what's possible.
It's an incredible field, and you have the power to make a real impact on people's lives.
So keep learning, keep asking questions, and never stop being curious about the amazing world of the cardiovascular system.
It's a world worth exploring.
It is. And until next time, keep that passion for nursing burning bright.